Okay, so we'll make a start. Good evening, everyone, and welcome to what is the 21st Cameroon Doctors in the UK webinar for the community. Our webinars are, in essence, a way for us to connect with our community on matters that are relevant from a public health perspective. And I'm particularly delighted with the topic that we have for you today. This webinar today is titled Endometriosis, What You Need to Know. It will aim to provide information on a common, often missed condition that affects millions of women worldwide. So how did we come to make this choice of this topic for this webinar? A few weeks ago, one of our colleagues got a message of a colleague's daughter who had done a podcast with a friend. And she shared that podcast with her. And after listening to the podcast and watching it, it became obvious to us that this was something that we needed to address with our community. So I'm delighted that Annie, who initiated and sent that podcast, is one of our panelists today, and we'll meet her later on this evening. Tonight, we have three panelists, Professor Justin Konje, Mrs. Annie Mbako Cunningham, and Dr. James Ombaku, who is joining us from Cameroon. In the background, please, if you have any comments and questions, put them in the chat box. We have a team of CamDocUK members that will be attending to your questions, maybe answering them. Some of the questions will be answered on the chat box. Some of the questions we will answer live in the discussion, and we'll try to get to all the questions either tonight, and if we can't address them tonight, we'll address them directly with you later on. So before we're going to make a start now, I'm going to introduce our first panelist, who is Professor Justin Konje. Now, Justin is an Emeritus Professor of Obstetrics and Gynaecology at the University of Leicester in the UK, and a mentor to many of us in this association and across the world in the field of obstetrics and gynecology. Justin, I'm sure, is pretty modest, but I'm going to say he's published in excess of 300 papers and book chapters. And all you need to do is just put his name into PubMed or Google Scholar, and you'll understand what I'm talking about. Justin has got enormous experience in the field of obstetrics and gynecology. He's one of those whose breadth of experience runs across both specialties. And he set up the first endometriosis clinic in Leicester. Justin will be discussing a general overview of endometriosis and how to manage this condition, particularly with reference to the UK. So thank you, Justin, and please, the floor is yours.
Thank you very much, Osric. Let me trying to share my slides. Right, so you can see my slides now.
Yes, we can.
Okay, great. Thank you very much. Good afternoon, good evening, good morning, wherever you are. Thank you very much for coming to this 21st webinar. It is indeed a real pleasure for me to be able to contribute to this on a topic that is very, very close to my heart. I hope that at the end of the day, we would have at least touched some of the questions that you have. I have to apologize that I know there are doctors on this webinar, but I'm targeting mainly the lay people who have very little knowledge or have some knowledge on what endometriosis is. So this is a cartoon that one of my patients in Leicester shared with me. And essentially, this is what her family thought of her for a very long time before she came to see me. And she was one of the patients suffering from endometriosis. So what is endometriosis? It is a condition where the tissue that is very similar to the one lining the womb shown here is located outside the womb. And this is an example of where this can be located. And because of where it's located, When the patient has her periods, this tissue here behaves as if it is the lining of the womb. And that causes very severe problems in the woman. When the woman is menstruating, the blood that you see here comes out through the vagina. But in patients with endometriosis, here rather, beg your pardon, in patients with endometriosis, the bleeding that happens here doesn't come out. It stays inside the woman's tummy. And that causes very significant problems. I'm trying to, right, that's better. So what I need to say straight up front is that endometriosis is not an infection. It's not contagious, so you cannot catch it from somebody who has it. It's not cancer, but we say that it behaves like cancer. And it's not a cause of death, but it causes very severe problems, as I'll be talking about this much later. How common is endometriosis? The sad thing is that we don't know exactly how many women are affected by this worldwide. But we suspect that between 1 in 6 to 1 in 10 women of the reproductive age group, giving us about 170 million worldwide, suffer from endometriosis. We take women who have difficulties conceiving, that number rises to about 40% or 2 in 5. Why do women have endometriosis? So I've said the tissues that are similar to the lining of the womb are found outside the womb. Why does that happen? Well, like one of the common things in medicine, we don't know exactly why it happens. So we call it a disease or condition of theories because there are many reasons that have been put forward. And this is just an example of some of the reasons. And I'm going to touch on a few of them, bearing in mind that most of my audience is not medical. 85% of women, when they bleed, when they have a period, the blood coming out, will also bleed backwards. We call it retrograde menstruation. That is quite common. Sampson, in 1925, postulated that within that blood are the cells that are viable. And when these cells stick on surfaces, they may grow. And they took this and put it in animals, and indeed, that was the case. But the question then is, if 85% of women bleed backwards, why is it that not every woman has endometriosis? Therefore, there must be a reason, and that some of the explanation is genetics, some is an abnormal immune system because your body has to fight to take these tissues away. But then when we look at other places where endometriosis is found, like in the chest, in the brain, this cannot explain it. So therefore, another theory put forward was that endometriosis may spread through blood vessels and other vessels to the distant parts of the body. But we know that people who are exposed to environmental factors such as dioxins, and what is the most common source of dioxins or PCBs? Plastics. That people who are exposed to a lot of these dioxins are also at an increased risk of endometriosis. But there are other risk factors. First one, of course, is the woman has to be in the reproductive age group. But it's not limited to this. So my youngest patient was 12 years and the oldest was 65. If the woman has difficulties conceiving, what we don't know is whether it's the endometriosis that causes it, or it is the difficulties in conceiving that links to endometriosis. This chicken before egg or egg before chicken conundrum. Family history, and I'm going to come back to that. The race, it doesn't spare any race, and it affects all social classes. In the past, it was known as the disease of the affluent, and I suspect that this was linked to the ability to pick it up in the wealthy people. There are a group of women who are born with some malformations either in the vagina, in the neck of the womb, or in the womb itself. And those women have an increased risk of having endometriosis. And of course, if your body cannot fight anything that is foreign, then you may have a greater risk. And the last group of women are the women who have what I call a typical menstrual pattern. And what is this typical menstrual pattern? Those that start menstruating very early, we call it early puberty. Most men will start menstruating around the age of 12, 11 to 13. If you start menstruating at the age of 8, 9, 10, if your periods are regular rather than irregular, you have more periods a year, i.e. the interval between periods is less than 27 days. If you have cramps, very severe cramps, then the risk of you having endometriosis is 4 times. If you have prolonged bleeding, that risk is 2.5 times. In terms of genetics, we know that the endometriosis that runs in families has a particular pattern. If the mother or the sister have endometriosis, for the mother, the daughter has a 7 to 8 times greater risk of having endometriosis. And if a woman has endometriosis, her sister has a 7 to 8 times risk as well. And what we also know is that for this type of endometriosis, it tends to be aggressive and is picked up at a more advanced stage. So where does this occur most often? On the ovaries, the back of the womb, and the side walls of the pelvis. And I'll show you some examples. But we can also have it in some unusual areas, on the pipes that go from the kidney down to the bladder. And there's a reason why I'm showing this. The womb itself, the tubes, the large intestines, and the appendix. And I've spoken about it being virtually in any part of the body, the brain, the chest, unusual places. And this is just a section through the abdomen and pelvis, just to show you the areas where endometriosis can be, just anywhere inside the woman's tummy. Of course, it can be in the chest as well as in the brain. So what are the typical symptoms of endometriosis? This will depend on the location. Of course, if you have endometriosis in the chest, the way it will present will be different from endometriosis in the tummy. But the most common symptom is pain. And this pain can be period pains. The woman has cramps, and I'll come back to this. And the periods may be heavy. She may have constant pain in the lower tummy that gets worse with menstruation. She may have pain that passes down to her legs, and this is very typical. Or she may get pain during sexual intercourse. And we call this deep pain. So it's pain after penetration. She may get pulling or stretching, and I'm going to come back to this, from scar tissue or what we call adhesions. I'll show you some examples. She may have infertility, but a significant number of women will have no symptoms at all. And you go into their abdomen, go into their tummy for something else, and you find that they have severe endometriosis. So this is my attempt to just explain the type of pain. Most women will have pain maybe on day 1, day 2 of their period, sometimes very heavy in the pelvis before the periods. And by day 3, the pain would have abated, would have gone. In endometriosis, there are 2 types of pains. You have the one in red here, where the pain starts on the day of menstruation, sometimes a day before, and then it rises to a crescendo around day 4, day 5, and then it lingers and then comes back down and disappears a few days after you have stopped menstruating. Or for the woman who has pain all the time, the pain gets worse during menstruation, reaching a crescendo around 4 to 5, 6 days into your periods, and then again, it falls back to the baseline level. This type of pain is very typical of endometriosis. But it can also present in other ways. Urinary symptoms, you're having pain or urinating blood mainly during periods, or passing urine a lot during your periods. Bowel problems, again, most often during periods. Constipation, vomiting, diarrhea. You feel as if you ain't completely empty your bowel because the endometriosis is pushing into the back passage. You're bleeding from the back passage when you're having periods, or you feel very bloated. The tummy swells up during your periods. And then we have the patients who cough blood, and I'll show you one of them that I saw. Or some patients come with swelling. They've had a cesarean section, and they bleed from the scar every month, or there's a swelling on the scar. How do you make a diagnosis? If you take a very good history and you examine the patient, in most cases, you make a diagnosis. In my clinic, I'll pick up 70 to 80% of my patients only from history. Examination is very difficult because sometimes you may not know what you're actually seeing, and it depends on how experienced you are. But we can also have tools that can help us to confirm the diagnosis. The three that are most commonly used are what we call a diagnostic laparoscopy. So you put a very fine camera into the abdomen, to the tummy, and have a look, or ultrasound scan, or MRI. In my practice, this diagnostic laparoscopy and ultrasound scan are the most important ones. Blood tests may not be that helpful, but it tells me when the patient has very severe disease or how she responds to treatment. What do we see at laparoscopy? It depends on the extent of the disease, its location, and the experience, the skills of the laparoscopists. I've had many patients who have come to me where somebody's had a look and said there is no endometriosis, and I've gone in and found endometriosis. Now, if you're the squirmish type, please maybe you should stop looking at the slides, the next series of slides. But this is what the normal pelvis looks like. This is the uterus here, the womb. These whitish things here are the ovaries. These long tubes here are the fallopian tubes. And then these pillars are very important because they support the womb. And the vagina is just in front of this area here. You can see that it's not very red. And I would like you to just take note of that comment. Now here we have a patient with endometriosis. You can see this area here is unusual. You see all these red lines are new blood vessels trying to supply blood to this endometriosis to make it survive. Then we have this patient who's got a big cyst in the ovary. We call it a chocolate cyst. So endometriosis, the woman is bleeding every month. The blood accumulates in the ovary, and then it gets bigger and bigger. And if it bursts, this thing comes out as melted chocolate. So we call it a chocolate cyst. This is what we call adhesions or scar tissue. So the normal intestines are free in the tummy, and they move around quite a lot, like wriggle like worms. Now, if you have this endometriosis here and you have scar tissue, it then attaches the intestines to the wall of the tummy. And then when this bowel begins to wriggle like the worm, it can move. So the patient has very severe and a pain that sometimes can be very incapacitating. Here we have another patient. Again, look at the bowel attached. But this time you also have this lesion here, this problem here, over this tube that goes from the kidney down to the bladder. This patient came with colicky pain shooting down in her pelvis, plus colicky pain all over her tummy from this. Here we have another patient. Again, this is a disease or the endometriosis over the pipe that goes to the bladder. And here we have the bladder. You can see that the bladder is now attached to the womb. You cannot see the womb at all. And this patient came because not only was she having very severe shooting pains, she was bleeding very heavily from her bladder every time that she was having a period. And this woman, endometriosis, had eaten into her vagina, making her vagina very tight and making sexual intercourse very, very difficult. And she was a married woman. And here we have, you can see very angry looking abdomen. This is the pelvis here. You can see blood. This patient is bleeding inside her tummy when she's having a period. And look at the intestines, all attached to the wall of the abdomen. Here, this woman's pelvis, you cannot even see her tubes, her ovaries. Again, very angry. Obviously, she would have had difficulties conceiving. And here's another patient. Just look at the amount of blood inside this patient's tummy during her periods. Undoubtedly, this woman will have very severe pain because blood is a potent irritant inside the patient's tummy. And this is the woman that I said came to see me because she was coughing blood every month and having very severe pains. And when I put my camera in her abdomen, we found these lesions in the diaphragm. So she had endometriosis of the diaphragm. Enough about my awful pictures. Is this diagnosis reliable? Is your laparoscopy reliable? Well, I always say to my patients that if a laparoscopy doesn't say you have endometriosis, it doesn't mean you don't have the condition. And this is so important because some patients go away thinking, well, I don't have anything wrong with me. So how you make a diagnosis will depend on the person doing the laparoscopy and whether you can pick up lesions or not. And I put this slide up because it's so important for the ordinary people who are listening that from the time that the symptoms appear, to when a diagnosis is made, and I'm talking about not only in the UK, but worldwide, it varies from 6 to 10 years. A study was published last year where they looked at 63 countries, and the average time was 9.6 years. And in this particular study, what they found was that from the time that the woman has the first symptom to seeing a doctor, the average was almost 4 years. Then from seeing a doctor to having a diagnosis made was 5 to 8 years. And this was shorter in the younger women, and in the older women, it was much longer. And the conclusion was, of course, that most of the physicians were not taking the patient seriously to make the diagnosis. And these were examples of some of the things that the women said. The doctor said, this is what it's like to be a woman. Every woman gets a cramp. I was told pain is a woman's lot in life. You are faking it for attention. They did not believe my pain. You are too young to have endometriosis. And it just goes on and on. And look at this, sexism, dismissal by doctors. Most patients, 82% between 18 and 24, 25 and 34, and then 35. Look at the numbers that the doctors said these patients' symptoms were not serious, and only a small proportion of them said the patient's symptoms were serious. Equally important, look at this, the numbers that experience sexism from female and male doctors. The pink shades here are females, the blue here are males, and then the reds are both. So a large number of doctors were sexist towards these patients. So what are the consequences of the delay in diagnosis? Well, the disease becomes more severe, the symptoms become more severe, it's much more difficult to treat, there's lots of work and family time, and it has a major impact on relationships and the psychological health of the individual. And of course, you have to pay more attention, more visits to the doctors. We did a survey in the UK, looked at 780 women. You can see that more than half of them had given up their job because of endometriosis. A third reduced working time. A quarter changed their jobs. A third claimed state benefit, so lost their jobs and claimed state benefit. 64% took time off work, and most of them lost more than a month every year from work. And of course, a large number of them had relational problems. Either they became divorced, they lost their boyfriends because of this. And what is the effect on the psychological health and relationships? And this is really important. You can see that almost 80% of the women have emotional stress. 69% become doubtful about themselves because nobody believes them. They have lower self-esteem. They have depression and anxiety in up to 90%, marital problems in up to 60%. What are the benefits of early diagnosis? Well, there's actually a relief that a diagnosis has been made. More socially acceptable. This is what a lot of my patients tell me. Now I can get on with my life because I know that it is not in my head. People have told them that it's up here and not something physical. They can then seek appropriate treatment and then less time lost at work, and it restores self-confidence and self-esteem. How do we manage endometriosis? Well, I'm putting this slide up to say that it is only the severe type that should be managed in an endometriosis center. Most doctors, including family practitioners, general practitioners, can manage the mild form of the disease. But the patient has to be at the center. The woman has to be at the center. And fitting into her treatment is a complement of many, many people, pain experts, the physiotherapists, nutritionists, support groups, family practitioners, psychologists. You can see that the doctors and nurses only form a small proportion. How is endometriosis treated? Well, we don't have any permanent cure for endometriosis. That is the bad news. But the good news is that the current treatment options can reduce the symptoms, can stop it from progressing, and in fact can actually make it regress. And the options are medical, surgical, or complementary. For the medical options, we base this on the fact that endometriosis rarely occurs before menopause. It remains quiet during pregnancy. Sorry, it rarely occurs before puberty, remains quiet during pregnancy, and it's rarely severe after menopause. So to do that, we need to give the patients painkillers, and then we mimic pregnancy or mimic menopause. And I'm not going to go into details. So we talk about pseudo-pregnancy state. You give the patients hormonal contraceptives. You induce menopause by giving them injections that cause menopause, or you can stop them from producing estrogens. In terms of surgery, we can just go and remove the lesions that we see or burn them, take the cyst out, or we can take the ovaries out and the tubes. Any doctor who is listening to me, please, if you have to take the ovaries of any woman out, you must take the tubes, because the tubes have been shown now to be the main cause of cancer of the ovaries. So if you're taking the ovaries out, take the tubes out. But I must caution here that taking the womb out, the ovaries and the tubes, does not guarantee that the symptoms will disappear, because HRT can in fact make the endometriosis worse. Does endometriosis occur after menopause? Well, not new endometriosis. As you heard me say, my oldest patient was 65 years. And if the patient goes on hormone replacement therapy, which is what we call HRT, it may make the endometriosis worse. Can cancer arise from endometriosis? Yes. If you take unopposed estrogen for a long time, cancer can arise in endometriosis. What are complementary therapies? We've got acupuncture, aromatherapy, all the lot. Do they work? Well, a lot of my patients will vouch for some of this, but I have no experience. How can we reduce the risk of endometriosis? Regular exercises. If you're jogging for more than 2 hours a week, it helps. Early pregnancy. I'm not advocating that all the young women should go and get pregnant very early, but if you are married and you want to have a family, you should start early rather than delaying it. If you're not, then use a combined contraceptive pill, because it does help protect not only endometriosis, but protect against other things like ovarian and bowel cancer. And then eating fruits that contain citrus can protect against endometriosis. Can anything else mimic endometriosis? We've got infections, irritable bowel syndrome, and maybe other non-specific things. And finally, if you have endometriosis, then you must look for support groups. There are many support groups in the UK, in the United States, and worldwide. And these support groups provide information leaflets. They also provide how you can help yourself. Thank you very much. I hope I haven't overrun, and I hope I've covered most of the things that I needed to cover. Thank you very much.
Thank you very much, Prof, for a very sort of comprehensive coverage of the topic. There are a few comments that and questions that I'll bring to your attention. But before I do that, I'm just going to remind everyone that if you have any questions or comments, please use the chat box at the bottom of your screen, and we will endeavor to answer all your questions and comments. We have a team of colleagues, Linda Bello, Dr. Montio Morgan, Anna Mbene, and Mafo Ayuk, who are in the background helping with this. Okay, so there's a few questions, Prof, and we'll get to some of the questions later on at the end of the talk too. So if I don't answer your question now, please don't be disappointed. So Maisa says, given that there's so many symptoms for endometriosis, is there a grading system that can help with the management?
Well, that's a really difficult question. So when I see women with endometriosis, what I tend to do is that I tend to try and prioritize and figure out which one is the more dominant symptom. Because when you are dealing with the symptoms, if, for example, somebody comes who wants to have a child and has endometriosis, you may struggle to give her drugs that will stop her from ovulating because she wants to have a child. So you have to prioritize that. So when we see the patient, we try and grade the symptoms, ask the patient which symptom is a priority, and then tailor management based on that particular symptom.
And that's sort of feeding through onto the next question. There's a question from one of our GP colleagues who asked, are there any, what sort of patients and symptoms would you be happy for them to manage before referring the patient on?
So that's really good, and I like that question, because one of the things that we advocate for is to initiate treatment early in primary care. So if you have any young girl from the ages of 11, 12 up to 22, 23 who has painful periods. Now, there are two different types of painful periods. You have the pain that comes, what we call premenstrual, or primary spasm, primary dysmenorrhea, that is primary pain with periods. So the pain comes a day or two before periods and then disappears around the second or third day of the periods. That is less likely to be endometriosis. But the pain that will persist into periods, and then even after periods, if you have that kind of a patient in your practice, or the patient says the pain is shooting down my leg, or the patient complains of bloatedness, severe bloatedness with periods, that is unusual, I would recommend that you can start that patient on the pill, the combined pill, give it for 3 months without a break. If they respond, then it means that they have something that is secondary to what is happening in their ovaries. And then you can put them on for 6 months and then refer them. That way, you're going to stop the disease from progressing and also make it possible for that patient to have better symptoms, better quality of life, and allow the secondary care to make a diagnosis.
And I'll just take one more question before we move on to our next panelist. And as I said, we'll come back to your questions later on at the end of all our panelists' presentations. Gisela is asking here, when you say unopposed estrogens, are you referring to the combined pill or any other kind of medication?
No, so we have, the combined pill contains estrogen and progesterone. So traditionally, you would give a woman, you not give unopposed estrogen to somebody who hasn't had a hysterectomy. So we tend to, for women who have a uterus, we tend to give them estrogen and progesterone, because if you give estrogen without without progesterone, you may make the lining of the womb to divide, and then that may have problems. What you do is you give estrogen, either combine it with progesterone in the combined pill, or you give estrogen and then followed by progesterone. That will be called combined treatment. Once a woman has had a hysterectomy, most people will just give the estrogen without the progesterone. That would cause the cells to divide, and keep dividing, and that is what might make them go into develop cancer.
Thank you very much, Prof. So I'm going to sort of move on to our next panelist, and Prof's not leaving yet. So please keep your questions and comments coming, and we'll address those at the end, as I've promised you. So I'm particularly delighted to present our next panelist, and a lot of the credit for today's webinar goes to her for coming up and sort of having a discussion about her experiences living with endometriosis. So Anna Mbako Cunningham is our next speaker. Anna is an independent consultant who's passionate about helping businesses develop inclusive processes. She's a change maker in the tech industry and has a background in biomedical sciences. Anna is currently at the end of a long recovery following a second operation with endometriosis, and she's determined to use her experiences to help people within our community take action after experiencing periods of isolation and coming onto the other side. So, Anna, it's a pleasure to have you with us this evening, and I'm sure attendees and doctors alike and professionals will benefit from the insight that you share about your experiences living with endometriosis. So thank you very much.
Thank you for having me on this platform. It's an absolute pleasure, having watched from the outside for so long. And thank you, Professor. As you were going through your presentation, this is the first time that I've ever actually heard a doctor speak where I think, yes, fully understand what I'm going through. You're telling bits of my life story. You mentioned in the start, or somewhere in the start, about a lot of a common factor in women who have endometriosis is that we start our periods early. It reminds me, I actually started my period in primary school, and I remember it was a badge of honor because I was the first girl in my class. And I didn't notice it. I had a white PE kit and we were just about to go out to PE, and the teacher pulled me back and said, no, you're bleeding through your shorts, come back. Little did I know that that was going to be the beginning of some very, very interesting years. I don't think I noticed that there was anything wrong with me in terms of my period until maybe I was a teenager. Yes, I remember some pain sometimes, but to be honest, a lot of us, as we get told, that pain is normal, and my symptoms always seem to change. So I never really tracked them. I always mistook them for something else. The most vivid memory that I have, earliest memory, is that I was in home economics class. I can't remember really what we were cooking, but I can remember that I smelled onions and all of a sudden I just felt sick. I needed to throw up. Now the door for the home economics class and the door for the toilet were diagonally opposite each other, literally is less than 3 meters apart, but I didn't make it to the toilet. So this little girl, the only Black little girl in a high school, made a name for herself. She threw up in front of the toilet. So every teacher and every student knew that that's what I'd done. And that happened just before my period. I just took it as, I don't know, maybe something that I'd eaten in home economics had made me, feel nauseous. But I didn't know that that was the beginning of my worst symptom of endometriosis, actually. And that nausea, I wouldn't say it became regular. And I remember going to college and being a frequent visitor to sick bay. And I remember also in my later teenage years, paracetamol and Nurofen were not working for me as a painkiller anymore. And in college, actually, the nurse introduced me to something called mefenamic acid. I don't think it was for pain. That's what I understood, but I don't think it helps you with pain. I also had other stronger medicines. I don't even remember what they were. They didn't work, but sick bay was really, really comfortable. So that's what I did. I went to sick bay. Nobody batted an eyelid. And then in my 20s, when I entered university, again, the pain became more intense. So I started feeling like I was being stabbed. I started bleeding super heavily, changing through lots of pads or bleeding through my clothes, bleeding to my sheets. These are all quite common things for a lot of women who go through a lot of different conditions. And again, I knew that, okay, maybe it's not quite normal, but I didn't think it was unusual because so many women around me were experiencing this. And I would experience these most months. So I became accustomed to these unusual symptoms. And I never thought that anything was really wrong most of the time. Then a friend in university, I know that she's the first person that told me about endometriosis because she was on private medical healthcare and she'd gotten this injection that knocked her out. And all I thought, as soon as she told me about it, I just thought, you know what, I need that injection. That's amazing. Something that stops you from feeling pain, it knocks you out and you don't feel anything ever again. I need to get that. I know I can't get it on the NHS, but if I can bring this up in some of my most severe doctor's appointments, maybe somehow somebody will look into something for me. So I kept going to doctors. I only saved, as I said, I saved my appointments or my interactions for them with my most severe episodes. So episodes where I really couldn't walk, I couldn't talk, I could barely open my eyes. I was like, there were several knives in my lower abdomen. That's the only way I can describe it. It was horrendous, horrific pain. I got given scans. I got prescribed pain medication, which I couldn't take because I was throwing up. I got put on the contraceptive pill a few times. Sometimes it worked, other times it didn't, and I ended up hating it. And I got told lots of times, have a baby. That's all very well and good if you've got a boyfriend, but I mean, my love life was fine, but it wasn't possible. And I had no intention of having a baby until I'd hit 30 years old, so that wasn't going to happen. And then I think things got worse towards my late 20s, into my 30s. It became particularly noticeable at work. So it started to take over when I would feel pain so severely that I would have to take breaks in the toilet or go and hide in the toilet in between work meetings. And I remember there was a point at my 30s where I used to work in the corporate world in a position where I was facing clients, giving presentations. And sometimes I would go to the toilet, have a rest, gather myself, go to the meeting, go to the presentation, then go back to the toilet to have a little nap. My team at work were absolutely amazing. They were so tolerant. And because I gave 100% when I was completely lucid, they actually accommodated me. And that's the only reason probably why I stayed in the job for so long. It was partly because of them, also because I had bills to pay, but partly because of them. And I think things took a really, really nasty turn at some point when I started feeling as if I had, I don't know, some kind of nerve pain or sciatica. I have no idea what it was. I just remember there was a point where I had joined a new Latin dance group doing Brazilian Zouk. It was so exciting, and we were coming up to our first performance. And as we approached the first performance, I just kept getting increasing leg pain. I couldn't walk properly. I didn't get a walking stick because I just thought, you know what, it's muscle pain from the dancing. And I went to a physiotherapist, who gave me some amazing treatments, put me on cryotherapy, which is really, really cold shots to my thighs. He gave me amazing massages. We tried acupuncture, so that's with needles and it doesn't hurt. And he also just tried physical therapy. So this is a great physiotherapist who worked with professional dancers, and everything he tried failed. He even gave me extra free sessions because he felt bad that he couldn't fix whatever was wrong with me. And it took a while, but eventually a doctor actually believed me that I might have endometriosis, and they agreed to do my first laparoscopic surgery. So it's the keyhole surgery that the professor was talking about. And initially they thought, you know, she's got endometriosis somewhere. We've done a scan, we can see something. Let's go in and see what happens. And the plan was to do a keyhole and I go home the same day. And what ended up happening is that they went in, they saw something that was horrendous. I had adhesions all over the place. So it looked as if someone had basically taken, I don't know, cement mix and poured it in my lower abdomen. Everything was stuck together, and the nausea, the pain, it started to make sense. So yeah, I had an operation that was a bit more like a C-section. They had to cut me open and do what they needed to do. And I woke up in a hospital bed a few hours later, completely off my head on morphine. And it took me about 6 weeks to recover from that. Mentally, it hit me hard. But after that, I just thought, you know what, what I was doing wasn't working. It definitely wasn't enough. So I decided to seek the help of a homeopath and a nutritionist. I changed my diet. I changed my way of living, or at least I tried. And I went to the homeopath that I went to. She was actually a woman who'd had endometriosis herself, really severe endometriosis. And she had this philosophy and this practice of helping other women to quell their symptoms, mainly through diet and other health practices. So she made a program for me and I tried to follow it. It was a very tough, severe program, I'll say that, a very big change from my lifestyle. And of course, it didn't last long. I still do some of those practices today, but there's no way that I could have done that. And my biggest worry as well, being a Cameroonian, I was just worried, what does this new routine for me mean? What can I eat when I go to barbecues? Can I still eat my pepper soup? Can I still eat pakoko and banga soup? Like, what am I going to tell my families? What am I going to tell my mom? Because she loves to send me food all the time. That was a massive worry for me because, as we all know, Cameroonians love food. Food is our biggest, I mean, it's also our biggest medicine as well. But over time, I think I kind of subsided in terms of the routine. I went back to some of my normal practices. But then I think things hit a climax last year. So about a year ago, it was probably the worst year of my symptoms. I really started suspecting that I had an allergy. I was in bed for about 3 out of 4 weeks around the start of March, let's say. 3 out of 4 weeks every month, throwing up severely. I couldn't keep food down. I think I'd lost about a third in weight, and I just, yeah, I couldn't hold it together. Initially, I thought it was an allergy. And then I was still seeing a specialist. I was referred to another specialist, referred to a specialist unit. And after doing, even more scans, the doctor said, you know what, I think you've got really severe endometriosis. He talked through in detail. Here are the scans. Here are the adhesions. Here's X, Y, and Z. And basically it was pretty bad. I wasn't coerced into having surgery. It was always an option. But at that point, the way that my life was, the fact that I couldn't hold down, I could never have gone into a stable job. I knew that I had to do this. It was either do it or I just don't know, because as you've heard a professor say, there is no real treatment for it. There are things to manage your symptoms, but I knew that it was pretty bad for me. I really didn't want to have another operation, but my mental health was absolutely in the toilet. I'd lost my hair and I was getting delirious from being drugged up. I couldn't think very well. And I was also putting pressure on my family. And I think the worst thing for me was that I was getting married, and on the way to, my special day, I couldn't actually maintain weight. So I'd started being maybe approximately a size 12 at the beginning of the year and dropped very drastically to a size 8, maybe even touching to a size 6. And as you can imagine, from a lot of my Cameroonian family, there were comments coming round, and what is wrong with you? You don't need to lose this much weight for your wedding. So they actually thought I was doing it on purpose. And I was actually struggling to put weight back on so I could fit into my wedding dress. And even just the basic thought of am I going to be okay? Is my period going to fall on or around my wedding day? That was a big, big fear for me. And so luckily, it was a bit of a wait, but I've had my operation now. And in the meantime, I still did things. I still hosted a tech conference. I still spoke at events, but I had to do those activities sporadically. Now, on the route to this, on the route to my wedding, I couldn't hide it anymore. I couldn't even keep a basic, phone appointment or coffee appointment with friends, with family, with potential clients, with my network. So I had to start telling people. And it's at this point that I discovered actually a lot of people have no idea, A, what this condition is. A lot of people have it and they're hiding it. And people that I know have it, or they have something similar, and they've never told me. They've never told me about it. So that's one of the reasons why I'm on here on this webinar. And I just want to finish by saying that there are 2 things I want to point out. My one thing in my journey so far that I really wish I could change, and it comes from my lens of being a diversity kind of person and consultant, is I wish that when I saw the leading figures of endometriosis, official endometriosis boards in the UK or wherever it is always an array of men. And I wish that there were more women gynecologists in that circle. So I don't know if there's anything I can do about it personally, but if there's anyone on here who's training and you haven't specialized, I'd really like to encourage you to go there, because it does make a huge difference as well to have somebody who actually has a womb. And there are not enough people like the professor or Dr. Ombaku around. There really are not enough doctors, and we need more women. And this isn't to say any of the gynecologists that I met, whether they were men or women, I've seen loads over the years, they were all the same. Most of them didn't know what they were looking at, and they couldn't offer me treatment. But the thing I'm most grateful for, I'm grateful for so many things, but my personal care team consists of my parents and my husband, because they have borne the brunt of this physically. And I think my friends as well, they know who they are. Some of them are on this call. They're keeping me sane. My personal care team have been absolutely amazing. But my final message to everybody, please, please, please do not sit in silence. If you are suffering from this condition, there are so many things online. There's so many communities. Get involved, start speaking to somebody, because I don't want you to end up in the situation where I was, where I could no longer hide it. And I was forced to speak. And, thankfully, I don't know we don't know what, you're not alone, basically. You're not alone, and we never know what you'll meet outside there, but you're really not alone. A lot of people want to help you. Thank you so much.
Well, thank you, Annie. I think we're very grateful for your sort of bravery in coming forward to address what clearly is something that's very uncommon and clearly debilitating. I mean, your story is an example of the sort of real tragic nature of this condition. And I hope, and I know for a fact that there are people that would have benefited from listening to you today. Everyone's saying thank you for sharing your story, for your bravery, and please keep sharing your story because it's definitely making a difference. I have a question that someone's just asked there. Is there anyone in your family that has similar symptoms as well? Do you know anyone else in your family?
Yes, there are. I know that they have symptoms, but they've not been officially diagnosed. But yes, there are.
Yeah, and that's interesting because I think Prof highlighted one of the risk factors was genetic. And I wouldn't be surprised if they only started mentioning the fact that they have symptoms when you came out describing what you were experiencing. Because there's a lot of people that are suffering in silence and assuming that this is normal, but actually this is not. The other question that I would ask, I think you may have some insight into this, is clearly as someone who's had this journey that you've gone through, if someone is in the situation where they're thinking, I may have endometriosis, what would you suggest to them when they went to see their doctors, particularly maybe their GP in primary care?
Oh gosh, that's a tough question to answer for me. And I'll say that because I have only just learned how to do this. And I have a woman who I call my sponsor because she is several steps ahead of me in terms of operations. And she was the one telling me what to do or what to say. And that's why I say you need to speak to people, speak to a community, because I only learned what to do and to get results by speaking to other people and having other people advocate for me. But you can't do it alone. And I think maybe Professor Konje might have some advice based on, because the fact that you definitely know more women who've been through it more than me, and you're on the other side as well. What can we say to doctors when we visit?
Well, thank you very much. Prof, did you want to make any comments?
Yeah, I mean, I think I like to say that women should make every effort to feel empowered about themselves and their symptoms. The reason why I went into endometriosis was because I came across somebody like Annie that really paralyzed me completely. I think if you go to see a doctor and they don't listen to you, go back and push them to listen to you. If they don't, seek for a second opinion. And there is a lot of information in the literature that is available, even in social media. You can actually channel to doctors. And I think one of the biggest mistakes that, and I think it's not, and I feel for the women, because from the slide that I've shown, if you find 70 to 80% of doctors just brushing it aside, and it's painful. I know you talked about women getting into endometriosis work. I think it's important, but I actually think that the most important thing is being able to understand and relate to what people are going through. You don't have to be a woman to do that. In fact, in my view, men are actually better because they don't know what it is like. So they tend to empathize a bit more. So my message is, please push and push and push. And for those who have children and have relatives, don't wait for too long, because if you wait for too long, these consequences can be more severe.
Thank you very much, Prof. There are lots of questions and comments coming through. We'll move on to our third panelist, and then we'll have a bit more time to address some of the questions. Please also check the Q&A box, because some of the questions are being answered in the background by the team of experts that are attending to them. So I'll move on to our third panelist, and it's a great pleasure to to present Dr. Kingsley Mbako, who is a colleague that works at the Bamenda General Hospital in Cameroon. This is critical for us because obviously as the Cameroon Doctors Group in the UK, one of the things that we feel is important is to have that link with our colleagues, share experiences, and contribute to improving healthcare in our country of origin and our communities back home. So Kingsley completed his medical training and specialist training at the University of Yaoundé, Cameroon. He is passionate about improving healthcare in Cameroon, and is also a lecturer at the University of Bamenda and the Catholic University of Cameroon. Kingsley has some experience managing endometriosis, and he will talk about some of the unique challenges that he faces as an obstetrician and gynecologist with regards to making a diagnosis of endometriosis in Cameroon. So welcome, Kingsley. Please, the floor is yours.
Yeah, thank you very much, and good evening to everyone. It's a great pleasure for me to be part of this webinar and to share our difficulties we have in managing endometriosis in Cameroon. Let me share my screen. Yeah. Okay. So good evening once more. So I'll present on the topic challenges of endometriosis management in Cameroon. As Anna has already said, endometriosis is a very challenging pathology to diagnose and even to manage.
Kingsley,
and if you can have those
presentation a slideshow, sorry.
Yeah. If you have those difficulties in Cameroon, you can imagine how much more difficult they will be in our setting in Cameroon. So the main issue with endometriosis in Cameroon or in Africa in general is that in the past, many authors had believed that endometriosis was not a problem of Africans. They thought it involved only women in the West. And all these misconceptions about endometriosis led to delays in diagnosis, misdiagnosis. You know, Annie talked about her delays in diagnosis, but in our setting, what is even worse is that most doctors will go on to manage it wrongly or to manage endometriosis as other healthcare problems, where the patient actually had endometriosis. It has also led to limited access to care and treatment in our setting, and also scarcity of research. There's actually very little research done on endometriosis in our setting. When you search, you see that very few have published any paper on endometriosis in our setting. In Cameroon, Prof talked about the gold standard for diagnosis and management, which is laparoscopy. Laparoscopy in Cameroon came actually very late in 1994. And before that, we were all in the dark. We never knew anything about endometriosis in Cameroon because we could not see it. And most often when you don't see a pathology, nobody takes it seriously. So some years later, Nana Mbene, the first person who carried out studies on endometriosis, was in 2006. He took the files of those who had been managed for chronic pelvic pain by laparoscopy and found out that 22.5% of them actually had endometriosis. Mbudu the next year also carried out the same study among all patients who had been managed for infertility and found out that up to 13.5% of them had endometriosis. So we quickly concluded that this problem had been a silent problem in our setting. And in 2017, a different study was done because many more cases had been done through laparoscopy by Sono and collaborators who found out that up to 33.7% of infertile couples who had laparoscopy had endometriosis. This was close to 3 times more than what Mbudu found. Not actually because it is increasing in our setting, but because we are searching more. And when you search, you find it more. And the latest study that was done in 2021 by Mustafa and collaborators in Douala found out that up to 3.12% of patients who consulted at the Douala General Hospital and Gynaecology Hospital in Douala had endometriosis. And their ages range between 20 and 49 years. This is how a typical patient in Cameroon in our setting, or my office, looks like. I had this case of a 32-year-old newly gravid woman who was a farmer, married for 7 years, who had been having severe menstrual cramps since the age of 20. So for the past 12 years, I've been having this severe pain, which became worse and permanent. And interestingly, this patient had been hospitalized several times for a wrong diagnosis. They talk of PID at one time, pyelonephritis, renal colics. And she had even been operated 3 times. She had an appendectomy, and nobody noticed endometriosis. She even had surgery for ovarian cysts twice, which I thought later were endometriosis, and nobody thought of endometriosis. So this patient who had scars on her abdomen from traditional practitioners came to us, and we ended up diagnosing endometriosis, and we put her on treatment. The treatment option that Prof. I will not dwell more on that, and the patient is actually feeling much better now. So why is it so difficult for us to manage endometriosis in Cameroon? When we see the cases we have in our consultations, we are tempted to ask the question if endometriosis is unexplored in our setting, if it is neglected, or if it has simply been forgotten by our doctors or healthcare authorities in Cameroon. So looking at the difficulties we face, the first difficulty we face in Cameroon is diagnostic delays. And this comes in 4 different ways. The first way is late consultations, because most of our patients are ignorant about the disease. Most of them have never heard the word endometriosis before. When you talk to them, sometimes they are shocked of the word, and they don't want to write it down to even cram the word because it's new to them. And most of our patients, when they have these symptoms, they seek to alternate therapies like auto-medication, traditional remedies, and prayers from various pastors we have around. Most of these patients also have this inability to express the symptoms they face, because most women look at menstrual issues, because as Prof said, one of the most common symptoms is menstrual pain. They look at expressing menstrual pain as a taboo subject, because nobody actually takes them serious when they talk about menstrual pain. The mothers will just say, oh, leave it, that's how I used to feel the pain, and you'll be fine. And when actually it could be endometriosis. There's also very poor sensitization on this disease by our healthcare authorities. We hear about all diseases on the radio all the time, but nobody ever talks about endometriosis. There's even a month of March, which is called Endometriosis Awareness Month, and very few centers actually preach endometriosis during that month. The next difficulty we have in Cameroon is access to care. Our patients that we diagnose are late because they don't have this care early. There are very few health care facilities in Cameroon. And even when we have care facilities, there are very few doctors, because most doctors in Cameroon are concentrated in the big towns. And in the suburbs, we don't have these doctors. And the specialists who can actually diagnose endometriosis, as Annie was talking about, gynecologists are very few. You can imagine the Northwest region, I think there are just about 4 or 5 gynecologists for the whole Northwest region. And then there's no dedicated endometriosis center. Prof would agree with me that when there's an endometriosis center where the difficult cases are referred to, they have an experience to manage all these difficult cases. We don't have that facility yet in Cameroon. The third issue is the poor knowledge by our healthcare providers on endometriosis, because most of our doctors who consult and nurses hardly consider endometriosis as a diagnosis. They prefer to think of the easier things like pelvic inflammatory disease, just simple menstrual pains and things like that. And even our training schools for health personnel and the ministry doesn't actually look at endometriosis as a problem. There's no emphasis on endometriosis when you are doing your medical training. And then we also have very poor referral practices. Most of the doctors who have patients who have problems that they cannot diagnose will hardly refer, sometimes because the patient don't have money to be referred to see the specialist, or because they just doesn't want to refer, they manage it otherwise, like the patient who are presented who had 3 surgeries wrongly for other pathologies, meanwhile she had endometriosis. And also lastly, there's very little research on endometriosis. Nobody thinks about endometriosis and they don't research on it. And the last difficulty in the diagnosis we have in our setting is absence of diagnostic tools. We talk about laparoscopy being introduced in Cameroon in 1994, and 30 years down the line, there are very few centers that still practice laparoscopic surgery. And even in these centers which practice it, less than 10% of surgeries are done by laparoscopy. There's also MRI, which is very rare in our setting, and good quality ultrasound. Ultrasound machines are dotted everywhere, but the quality is not actually good to pick up endometriosis, and even the technicians who do it don't diagnose endometriosis. Coming now to the management proper, what difficulties do we have? As I've already said, there's a problem with late diagnosis. Prof talked about average of 7 to 9 years in the West. In our setting, some people may even die without even being diagnosed of endometriosis. And even those that we see come very late, an advantage of the disease, which makes diagnosis in a difficult setting even more difficult for us to manage. And secondly, our patients have, in Africa, the fertility desire is very strong. And while you are receiving endometriosis treatment, you cannot get pregnant during the treatment. And if you want to offer radical treatment, patients always resist because they want to get pregnant immediately. They don't have that patience to wait. Then there's no dedicated endometriosis center or specialist in Cameroon. We are not lucky to have a prof in our setting who can manage endometriosis. And then high treatment costs. Prof talk about GnRH analog, some treatment that we give. In our setting, it costs about 240,000 francs for a treatment that the patient will take to cover a period of 3 months. You can imagine the poverty we have, how many patients can afford that. Even the surgery is difficult for them to afford. And laparoscopy, as I said, is many hospitals don't have it. And even the centers that have few people know how to use them, which makes diagnosis even more difficult. And then we don't have any support groups to manage our patients because when patients have endometriosis, it's a very difficult moment for them. They are psychologically down and they need this psychosocial support to support them and bring them up. And what is the way forward? We have a lot of challenges. We have not folded our hands. There are many things we are trying to do. Some are doing well and some are doing poorly. We are trying to raise vital awareness on the public about endometriosis, its existence, first of all, because many people don't know it exists, and the symptoms. And many centers are now trying to celebrate Endometriosis Awareness Month every March, like at the regional hospital in Bamenda, we celebrate that, to ensure that healthcare providers who have made it in our hospital that anybody who has symptoms, we must consider endometriosis. Not that anybody who has the symptoms that Prof said has endometriosis, no, but when you have those symptoms, we try to exclude, to investigate, to see if endometriosis is one of the problems you have. Next, we would like to partner with foreign experts like Prof, of course. We have done that in other pathologies like cancer. Dr. Former in the US is helping us a lot to manage our cancer patients. If we have this partnership with foreign experts, it will have great help to us because they have this experience in endometriosis, to create support groups and also to encourage research on endometriosis. When you read literature, they will say chocolate cysts are the most common symptoms, but in our setting, those things are rare to find. So we want to know which forms are common in our setting and how to best manage them. I just talked about Endometriosis Awareness Month. In March, we carried out a campaign on endometriosis screening for chronic pelvic pain. And we saw that many patients had endometriosis that had been undiagnosed for a long time. And during that presentation, I was blessed to have an award, the Staff of the Month, because of the sensitization campaign we did on the management of on diagnosis and management of endometriosis. And many patients were diagnosed during that screening campaign, and our care now are following them up very closely. This is our theater in the regional hospital. We have this laparoscopy that we diagnosed. This is actually the case I presented earlier. We diagnosed that she had this chocolate cyst. She had many endometriotic lesions. Prof had already shown you the images. I will not scare you more images. So we do these things in our setting. So we can just conclude by saying that endometriosis is not an uncommon pathology in our setting as previously thought. It's a very serious problem in our setting that needs special attention and support for those who have been working on this issue in other countries. And because of these difficulties, diagnosis is often late in our setting, and management is facing very serious challenges and generally suboptimal in our setting. So vital awareness on the population and even the healthcare providers, and also linkages with experts abroad is very important and indispensable for us to manage our patients with endometriosis. So thank you very much for your kind attention. If there are any comments or questions, we'll answer them. Thank you very much.
Thank you, Doc. It's on behalf of CamDocUK. I'm sure the rest of the members join me in thanking you, one, for joining us today, but two, for the work that you do in our community and the steps and the progress that you're taking towards addressing clearly what is an often neglected problem. So we're very grateful for that. There's a couple of questions. The first one, really, you touched on this, but I'm gonna ask, how can CamDocUK as an association really be helpful in terms of the agenda on endometriosis? How do you see us helping? How do you think we can help here?
Yeah, thank you very much. I think the help has already started. This webinar, when we shared the Zoom link, many people were enthusiastic about the issue and tried to join. So I'm sure many people who are listening now are going to help us to propagate this information about endometriosis, because one of our major challenges is that many people don't know about endometriosis. So we have to start from the grassroots to inform them. Next, we would like to end CamDocUK to maybe organize sessions where we can meet doctors, maybe sometimes, or even inform doctors that you know back at home to always consider endometriosis as a diagnosis. And lastly, we would like to partner with doctors in CamDocUK, like Prof, to help us, empower us on how to diagnose and manage these cases better. Thank you.
Thank you, Doc. Prof, do you have any comments on that before I ask the next question?
No, I think that CamDoc can and ought to provide some mentoring and support. Nowadays, with the technology that we have, it should be possible to even organize occasional discussions with people like Dr. Kingsley and others who where we can actually provide virtual advice. And really nothing stops. I mean, I've had occasions where I've actually had to look at laparoscopic images from a remote site and offer advice on what to do. So we can explore this, and it's not necessarily having to have somebody be there physically, although I think it would be nice to be there physically, but we don't have to. But I also think that one of the things that CamDoc should look into is potentially supporting people like Kingsley with providing. Can I go ahead?
Yeah, go ahead.
Right. So CamDoc can look at a way of maybe finding some support for those highly specialized medications for the small group of patients that would benefit from it maximally. That, I think, would go a long way to supporting Kingsley, Dr. Ombaku, and colleagues in Cameroon.
Thank you very much, Prof. There's a whole list of questions that we're going to try and address for the rest of the sort of 15 minutes that we have before the end of this webinar. Dr. Kingsley, I'll pose this one to you. It's a question that one of our attendees is mentioned. She's asking what the difference is between a fibroid and endometriosis.
Thank you very much. Fibroid and endometriosis are two different pathologies. A fibroid is a benign tumor, it's a growth, benign tumor from normal cells that grows on the uterus, from the smooth muscles that line up the uterus. It grows from the uterine muscle. And endometriosis, on the other hand, is when the inner lining of the uterus, the lining where menstrual flow, where menstrual blood comes from, leaves the endometrium, they call it the endometrium, and finds itself in other parts of the body, which could be anywhere, most often in the pelvis, like the ovary, the tubes, or the pelvic lining, and it starts growing there. It's functional tissue. So during your menstruation, while you are bleeding from the uterus, those other locations where the endometrium is found will also have some bleeding or adhesions and other problems. So there are two different pathologies.
That's right. I mean, I'm sure there may be some common symptoms between the two. So maybe that's partially why our attendee is confused. So there may be some common symptoms between the two, right?
Yes, there are some common symptoms between the two, like painful menstruation. Those who have fibroids sometimes may experience painful menstruation, but not always. And so those guys, the gray area between the two. But there are two pathologies. In fibroids, for example, you feel a mass on the uterus when the fibroid is large. In endometriosis, you don't feel any mass on the uterus.
Okay. Thank you very much, Doc. So I'm just going to go through.
Just a comment to say that there is a small group of women who will have fibroids and endometriosis coexisting. And endometriosis appears to be slightly more common in women with fibroids than in women who don't have fibroids. And that's probably linked to what causes the fibroids to grow and what causes the endometriosis to grow.
Thank you very much, Prof. Another question that sort of is coming up is someone's trying to understand what's the cause of the shedding of the walls of endometriosis during menstruation and how can it be treated? So she's asking, what is the cause of this endometriosis during menstruation? And I know you sort of mentioned it, but I think it should probably benefit from hearing it again.
Okay, I think I typed an answer. But essentially what happens is that at the beginning of a woman's menstruation, the ovaries start producing hormones that are called estrogen and progesterone. And the estrogen causes the lining of the womb to grow and grow and grow. And progesterone is like a cement. It puts it all together. Now, if the woman doesn't get pregnant, the level of progesterone drops. When the level of progesterone drops, it's almost the cement, which is supposed to put or hold all those tissues together, breaks. And when that breaks, the woman bleeds. That's what causes bleeding, menstruation. And it's exactly the same thing that happens in endometriosis. So the estrogen levels rise, progesterone causes the tissues to be together. When progesterone falls, it breaks. That's what the bleeding, that's why the women menstruate, and that's why they bleed in the endometriosis.
Thank you very much, Prof. Another question here is, I know it's been answered by someone in the text group, but I think it would be beneficial for the audience at large to hear this. It's a question about, since endometriosis is estrogen dependent, are there any foods that you would advise your patients to avoid that may be helpful in terms of helping the symptoms, particularly with our context?
Are you asking? I'm waiting. Who are you asking? Annie?
No, you, Prof.
Me?
Yeah, are there any foods that you would avoid? I mean, from the point of view of estrogen-rich foods, I suppose that's where the question is coming from.
Look, I really don't know of any specific foods that. Okay, I would say that all intent and purposes, we should avoid foods that will significantly increase fat. Now, I mean, it's just common sense. So the reason why I'm saying this is if I said that even if you take the ovaries out, the woman may still have endometriosis, may still have symptoms of endometriosis. That is because in everybody, there's a fairly significant amount of estrogen that is produced in fat. And so the more fat you have, the more estrogen you're going to produce, and therefore that's more likely to propagate the endometriosis. But I'm also aware of the fact that, unfortunately in Europe, for example, there's a lot of estrogen in what is being eaten, what is being processed foods, in beef that is processed, in other things. And we know that this has been responsible, for example, for the drop in the sperm count in men in Europe. So the other thing I will advise against is eating too much processed food. Processed food also contains a lot of PCBs. Somebody asked me when I talked about plastics, what do I mean? So avoid heating plastic, for example. Avoid putting hot food in plastics. Avoid eating anything that has been stored in plastic for a long time because it contains dioxins, which have been shown to increase the risk of endometriosis. But if you eat food that contains citrus fluid or contains a lot of things that have a bit more acidic, then you're going to reduce the risk of endometriosis. I don't know whether that helps.
Yeah, I think that helps. Annie, in your lived experience, was there anything that you found that avoiding was helpful?
Yes, and I'm just going to put a disclaimer out there that I also think I'm trying not to give advice, because I think everyone should also seek advice from professionals, or if you want, online, and your body will work differently. Everyone's body will work differently. But for me personally, not eating meat, specifically because in the UK, standard chicken, when it's non-organic, is injected with estrogen to help the chickens grow, or for whatever reason they do it. So I found that actually cutting out most meat from my diet significantly helps. Every time I've done that, it's been, the difference has just been, it's been very noticeable in my cycle. So I now, well, I'll try. Most of the time, I do not eat chicken. I do not eat meat unless it's offal. So I can't resist something, but those are some things that I don't do. And the not heating food in plastic, I've been trying to do that more and more often because I have heard that as well. I have been told by a consultant as well to avoid dairy. Apparently, they tell all their patients to do that. And that might be, I'm saying, in the reason why I say in the UK is because there are different additives put in food where you are. So those of you who are in Cameroon, your food might be more organic, less processed. So you need to worry less about those things. But certainly if you're in the UK, the US, yeah, you need to eat really healthy. You need to eat as fresh as possible, and try and cook things or see things, eat things that you can see being cooked naturally. So the irony is Cameroonian food is great for that because we have to make it from fresh, but we love to put loads of meat in. So what I'll do is just, I don't usually tell people that I'm not eating this or that. I will just go to a party and I'll take what I need and, you know, leave the rest there. So it's quite easy. It hasn't disturbed my life too much, and it is possible to do. It's not easy, and I never thought that I would be able to sit next to my husband eating a steak and I wouldn't feel you know, hungry, but I did that last night and I've been doing it for a while. So it is possible to do, it's possible to live a very full, rich life, and we can still eat our Cameroonian food. That's the best news.
Thank you, Annie, for that insight. And I'm glad you sort of put the caveat about appropriate medical advice. Thank you very much. Another question that's come up, Prof, and I think this is a really important one, is it's a question about what's the difference between an adenomyosis and endometriosis, because someone's asking that they know someone who was diagnosed with adenomyosis, and is the treatment different?
So adenomyosis, up to maybe 10, 15 years ago, the two conditions were grouped under endometriosis, but we now look at them as different entities. So adenomyosis is actually a condition where the cells that line the womb grow inside the muscle of the womb itself, rather than outside the womb. And so again, because they bleed and the blood doesn't come out, it stays there, it causes the womb to grow, and they have very severe pain. So the symptoms, by and large, there is an overlap with the symptoms. But often patients with adenomyosis will have the womb that is just slightly enlarged, it's uniform, and it's very tender, and the periods are more likely to be heavier compared to those who have endometriosis. But they also have pain that often starts before menstruation. It will, just like I showed that, the pain rising to a crescendo and then falling. For most of those patients, the pain never falls down to baseline because they have this blood that is retained inside the womb. So those are the major differences in terms of the two conditions. For treatment, if you look at medical treatment, it tends to be the same, because what is responsible, what I call like the feeder, what keeps the endometriosis to grow is the same thing that keeps the adenomyosis to grow, is the estrogen. So if you stop estrogen, or you give anything that will counteract the effect of estrogen, you make the adenomyosis to shrink and reduce in size. And so that is, there are now modern methods that are being used where you can just direct radio frequency waves into the area where you have the adenomyosis and burn that. But that's very highly technical. In terms of what we do at the moment, we just give them drugs. And again, it might reduce fertility, but not as much as endometriosis.
Okay, thank you very much, Prof. Again, there's a few more questions to go. I hope we can get to answer them all. There's a question here that talks about the treatments that you mentioned regarding hormonal treatment. And she's asking the question, isn't taking the womb out a bit too excessive, and HRT is not that great an option. In fact, she says rubbish. Can doctors not look at natural remedies as an alternative in this condition of endometriosis?
Right. So you almost like, I rarely offer taking out the womb of a woman to treat endometriosis because it isn't the cause of endometriosis. And taking out the womb alone does not treat endometriosis. So I don't regard that as part of the treatment for endometriosis. However, if you have a case where the womb has been pulled back by scar tissue, and the scar tissue is causing very severe pain in the patient has completed her family, you may have to take the womb out because of the pain and discomfort that comes from the scar tissue. Taking out the ovaries, in my view, is radical. That's why I call it radical. It's really going very far. But often you do this because no other thing has worked. And the woman has come to the end of her tether and said, look, I can't cope with this anymore. There are some women that I describe as having refractory endometriosis. So you've tried everything and it doesn't work. Now, you have to be an extremely uncaring person to look at somebody who's maybe in their 40s or in their late 30s who says, I'm not going to have children. My life is really, I can't cope anymore. You're saying, look, well, we shouldn't take your womb out. We shouldn't take your ovaries out because of this. No. So I think it's really based on the symptoms of the patient. And you're right, but there may be things that you can do, which is why I talked about complementary therapy, which is why I talked about other forms of treatments that if they work, fantastic. But if nothing works, and that's the only option, the most important thing is making sure that you educate the individual properly before they make that choice. It's not for me, the doctor, to make the choice.
Thank you very much, Prof. A couple of last questions. Number one, is there a link between endometriosis and estrogen-receptive cancers?
This must be from a doctor.
Yes, it is.
Well, the answer is, and I need to be extremely careful about how I phrase this. The two types of estrogen cancers. There's a type 1 and type 2. Well, cancer of the womb anyway. But also cancer of the breast is estrogen. Again, there are two different types of estrogen receptor cancers in the breast. So obviously, I'm not aware of women who have endometriosis who have a significantly increased risk of having cancer of the womb. However, because women with endometriosis are more likely to have difficulties becoming pregnant, and we know that not having children increases your risk of having cancer of the womb, which is estrogen dependent, I would say that there is a tenuous link between the two. And the type of cancer that would develop in the endometriosis is a type of cancer that is very similar to the one that develops from the lining of the womb, which is estrogen sensitive.
Thank you, Prof. And the final one is again from a doctor. And I think it's a really useful question. She asked, is it required for every patient undergoing medical treatment for clinically diagnosed endometriosis to still undergo a confirmatory test like laparoscopy or MRI, or is a satisfactory response to the therapy in itself enough?
Well, that's a really good question. And I remember, so we wrote an article in the BMJ called Easily Missed. And this was directed at general practitioners. I think if I'm a patient, I would like to know what I have. The timing of when I do the test is very different. Why am I saying this? So if I know that I have endometriosis, and I know that the treatment that are giving me is working, I know that if I don't comply with that treatment, it might get worse. I might get very, very, very bad. And I will have the motivation to comply. I will also be motivated to do the sort of things that Annie's talked about, avoiding processed food, avoiding food that contain a lot of estrogen, things that can make the endometriosis worse. If I did plan to have a family, I will go ahead with that a bit earlier rather than delaying it. So I would say that if you've treated the symptoms and they're working and the treatment is effective, if the most important thing, of course, is that you're treating the symptoms, because that stops the disease from progressing. That is an amazing thing. So if you do that, that's great. You can do it for 6 months and then give it a break. Because usually after 6 months, the endometriosis has either shrunk or it remains dormant. Then it takes a bit of time before it's reactivated. And then if at the end of 6 months, if the symptoms reoccur, you can send them to go to the hospital and let it confirm the diagnosis. If I did a laparoscopy and I found endometriosis, if it's easy, I just burn it. So that's, again, you're stopping it from progressing. So that would be my own advice here.
Okay. So there's a couple of final questions before we stop. For Dr. Kingsley, there's a question asking about if there is a relationship between sexual activity and frequency of sexual activity and appearance or onset of endometriosis. And if someone abstains from sex, can endometriosis become a consequence of non-sexual activity?
I would say there's no link between sexual activity and endometriosis. Because of endometriosis and its etiology, which is not actually well known today, as been explained by Prof already. But on the other hand, I would say that for those who are involved in sexual activity, endometriosis will cause pain during sexual activity. And this patient, sometimes that pain may prompt us to diagnose endometriosis faster in this patient.
Thank you very much.
That activity will be pain.
Yeah, okay. So the final question before we finish, again for you, Dr. Kingsley, is someone's asking about your recent screening exercise. So did you have to do a laparoscopy on all the patients that you diagnosed with endometriosis, or was it just some of it was based on symptoms alone?
We counseled patients on the symptoms of endometriosis, like chronic pelvic pain, bowel irritability, especially during menses, and other symptoms Prof talked about. And those who had these symptoms had to come and consult. They consulted at 2 different levels. We had GPs who would screen them. And if they think they have symptoms, signs of endometriosis on physical exam, they will send them to us. And when we receive these patients, send them for ultrasound. And if there are any suggestive signs, there are some in whom we actually did laparoscopy, and we found endometriosis in them. So endometriosis, laparoscopy is a surgery. We don't want anybody to undergo that kind of surgery. So it's in those that we actually thought very strongly that had endometriosis who went on to do laparoscopy.
Thank you very much. So this brings us to the very end of our webinar this evening. I am grateful for everyone that's taken the time to attend this webinar on a Friday, Saturday evening. I'm very grateful and thankful to our panelists. Thank you, Dr. Kingsley. Thank you, Prof. But most especially, thank you, Annie, for your bravery and your courage in coming forward and starting what we hope will be an ongoing discussion. Before we finish, there's a Survey Monkey in the chat box, which I would welcome everyone. I'll ask everyone to fill, because this is what helps us to decide what our next topics will be and what you think will be beneficial for you as the community that we're trying to serve. So please complete the survey in the chat box. And finally, I'll put a plug in for our annual general meeting, CamDoc annual general meeting, which is coming up on the 29th of June at the Leonardo Hotel in Hinckley, where the theme will be towards better outcomes for mothers and babies. So please, if you're able to join us, it's an annual gala dinner, a very Cameroonian way of doing things. If you're not Cameroonian, you can join in, but we're also raising funds. And if you are able to donate towards our cause, please there's always a need for donations to help us attain the things that we're trying to do. So thank you, everyone. And I hope you had a pleasant evening. Thank you, and good night.